In this module, we will be discussing neurological disorders. Student learning outcomes. Upon completion of this module, the student should be able to describe the common complaints associated with neurological problems, discuss causes in the clinical presentation of common neurological problems, discuss diagnostic methods, differential diagnoses, and management of common neurological problems, utilize critical reasoning skills to assess, diagnose, manage, and evaluate neurological problems in the adult and geriatric patients, provide individualized management of common neurological health problems of adult and geriatric patients, and incorporate interdisciplinary care, incorporate teaching of the patient and family in the process of managing chronic neurologic disorders. In this module, we will review the anatomy and physiology relating to neurological disorders. We'll also discuss common complaints, common problems, as well as infectious disorders. This diagram breaks down the nervous system into two sections, the central nervous system and the peripheral nervous system. In the central nervous system, we have the brain and the spinal cord. In the peripheral nervous system, we have the cranial nerves, the spinal nerves, and also the autonomic and somatic systems. The brain is a very important component of the central nervous system. As you can see in the diagram, it is broken down into the different parts of the brain, which include the cerebral cortex, basal ganglia, thalamus, hypothalamus, cerebellum, brainstem, and the spinal cord. The cerebral cortex has two hemispheres, which are each divided into 4 lobes. The left hemisphere is dominant in about 95% of people, including those who are left-handed. The left side of the brain is the seat of language and processes in a logical and sequential order. Now, on the right side, it is more visual and processes by intuition, holistically, and randomly. As mentioned earlier, the cerebral cortex is divided into 4 lobes. These lobes are the frontal, parietal, occipital, and temporal. Being familiar with these lobes can help when treating a patient who presents with a neurological disorder. Going into more details on the 4 lobes of the cerebral cortex, we have the frontal lobe, which is responsible for personality, behavior, emotions, and intellectual function. There's an area which we call the Broca's area, which is responsible for producing language. It controls motor functions involved with speech production. When people have damage to this area, they present with expressive aphasia, which is where the brain can understand words, but it struggles to put them together into speech. Next, we have the parietal lobe, which is responsible for sensation. The occipital lobe, which is responsible for visual reception. And then we have the temporal lobe, which involves the auditory reception. And then in this lobe, we have an area called the Wernicke's area. And when this area is damaged, patients may present with receptive aphasia, where they hear sound, but it has no meaning. The basal ganglia is buried deep within the hemispheres. It is associated with a variety of functions, including the control of automatic associated movements of the body. Examples include arm swinging, alternating of the legs while walking, eye movement, and so forth. The thalamus is a small structure within the brain. The main function is to relay motor and sensory signals to the cerebral cortex. The hypothalamus is also another relay station. It involves the control of temperature control, the sleep center, and also the anterior and posterior pituitary gland regulation, and also is considered the coordinator of autonomic nervous system activity and emotional status. The cerebellum involves motor coordination of voluntary movements, equilibrium, and muscle tone. It does not initiate movement, but coordinates and smooths it. It operates below a subconscious level. The spinal cord is a very important aspect of the central nervous system. It is broken down into the cervical, thoracic, lumbar, sacral, and coccygeal regions. In the diagram, you can see specific nerve roots relating to each region. The central nervous system has motor and sensory pathways. Cortical spinal or pyramidal tract controls fine movements, and extrapyramidal tract maintains muscle tone and controls body movements, especially gross automatic movements such as walking, which is commonly affected in Parkinson's disease. The cerebellar system coordinates movement, maintains equilibrium, and helps maintain posture. The peripheral nervous system includes the cranial nerves, spinal nerves, somatic and autonomic nervous systems, and the reflex arc. The cranial nerves include 12 pairs that enter and exit the brain. They supply the head and neck except cranial nerve 10. The spinal nerves include 31 pairs. The cervical region has 8. The thoracic region has 12. The lumbar region has 5. The sacral area has 5, and the coccygeal area has 1. Also included in the spinal nerves, we have the dermatomes. A dermatome is an area of skin that is supplied by a single spinal nerve. In the diagram, you can see the dermatomes more specifically. There are 12 cranial nerves. Each nerve serves a specific purpose. Some are for sensory, some are for motor, and some are for both sensory and motor. Cranial nerve 1 is the olfactory nerve, which involves the sense of smell. Cranial nerve 2 is the optic nerve, which involves vision reception. Cranial nerve 3, oculomotor, involves eye movement. Cranial nerve 4 is the trochlear, which also involves eye movement. Cranial nerve 5 is the trigeminal nerve, which is responsible for sensation in the face and motor functions. Cranial nerve 6 is the abducens, which is also responsible for eye movement. Cranial nerve 7 is the facial nerves, which involves the eyebrows and facial movements such as frowning, closing the eyes, and smiling. Cranial nerve 8 is acoustic, which is for hearing. Cranial nerve 5 is a glossopharyngeal, which involves swallowing, the uvula, and voice. Cranial nerve 10, the vagus, involved with the gag reflex. Cranial nerve 11 is a spinal accessory nerve. And cranial nerve 12 is the hypoglossal nerve. There are many different ways to learn how to remember the cranial nerves. In this PowerPoint, we use the mnemonic. On old Olympus, towering tops, a Finn and German viewed some hops. Becoming familiar with cranial nerves and their specific functions and purpose can help when treating a patient who presents with a neurological disorder. For example, if a patient presents with ptosis, you may look into cranial nerve 3. If a patient has problems with their speech or articulation, you may focus on cranial nerve 5, 7, 9, 10, or 12. In the aging adult, there are developmental considerations. These include delayed reaction time, decreased touch and pain sensation, decreased muscle strength and agility, and also decreased cerebral blood flow. Common chief complaints of neurological disorders are confusion, dizziness, vertigo, headaches, and tremors. Patients who present with these complaints need to be further evaluated. An assessment on a patient whose chief complaint involves a neurological abnormal finding should include the chief complaint, HPI history, review of systems, mental status, cranial nerves, motor function, coordination and gait, sensory, reflexes, and specific tests. Confusion is a symptom, not a disease process. It is defined as the inability to think clearly or coherently. It is a key sign of neurological disorders. A lot of times this complaint may be very different and may be noted while assessing the HPI. The mini mental status exam is a widely used test to help determine the cognitive function of the elderly. Some clinics use all of it, and some clinics use just part of the exam. Findings that may be related to confusion are disorientation to time, place, or person. It may appear suddenly or gradually, may be temporary or irreversible, may be due to stressful events such as lack of sleep, food, or sensory deprivation. Age is not a reliable predictor. Polypharmacy may contribute to this symptom as well. On page 76, there's a chart, 6.1, that shows more information. Differential diagnoses that may contribute to confusion are delirium, dementia, metabolic disturbances, infectious process, and tissue hypoxia. In your book, on pages 77 through 78, Table 6-1 compares delirium versus dementia. Delirium is a serious disturbance in mental abilities. It is acute, transient, and usually reversible. Often, patients will have confused thinking and reduced awareness of the environment. As mentioned before, the start of delirium is acute. It usually is rapid. It can happen within hours or a few days. There is an increased incidence of dementia in people who have experienced delirium. Delirium can often be contributed to one or more factors. Such factors are severe or chronic medical illness, changes in metabolic balance, such as low sodium, medication, infection, surgery, alcohol or drug withdrawal, and a change in the environment. Dementia is a gradual decline in mental functioning affecting cognition, memory, language, and personality. It is not a normal part of aging. A sign can be progressive loss of intellectual abilities such as thinking, remembering, and reasoning that interfere with activities of daily living. Dementia can accompany or be part of many diseases and physical conditions. Alzheimer's disease is the most common cause of dementia. This PowerPoint demonstrates a comparison of delirium and dementia. The next chief complaint related to neurological disorders that we will be discussing is dizziness. Dizziness is the second most common complaint heard in a doctor's office and will occur in approximately 70% of the nation's population at some time in their life. Dizziness is the sensation of unsteadiness and feeling of movement within the head. Often, patients will complain of having the feeling of being lightheaded, woozy, or unbalanced. Dizziness involves and affects the sensory organs, specifically the eyes and ears, so it can sometimes cause fainting. Dizziness can also be a symptom of various disorders. Vertigo can be defined as the sensation of rotation or movement of the patient or surroundings. It may result from inner ear or disturbance in the vestibular center. Patients may complain of a spinning sensation, like their room is moving, or they may feel like they have motion sickness or as if they're leaning to one side. They may also present with a nystagmus. With that being said, it is important to remember that true dizziness is a feeling of lightheadedness or nearly fainting. There are several different causes of dizziness and vertigo. Examples of factors that may contribute to the dizziness are sudden drop in blood pressure, hypoxia, obstruction in blood flow, decrease in blood volume, hypoglycemia, and anxiety disorders. Examples of factors that may contribute to vertigo are benign proximal positional vertigo, which is the most common cause of vertigo that often occurs when a patient goes from a different change in position, usually from sitting to standing really quick. In that case, you would want to tell the patient to change positions slowly. Another factor could be an acoustic neuroma and also Meniere's disease. When you are dealing with a patient who complains of dizziness or vertigo, it is important to clarify what that patient is experiencing. There are several red flags to be on the lookout for. Examples are if their history is inadequate, you definitely want to presume that it could be cardiovascular and you want to perform different diagnostic tests and labs to rule that out. Examples are EKG, cardiac enzymes, cardiac monitor, or an echo. It is very important to arrange cardiac tests, especially while they're symptomatic. If a patient has altered consciousness or behavioral change, you definitely want to exclude epilepsy and exclude the cardiac or cardiovascular causes as well. Vomiting can be another sign that helps to clarify and determine whether dizziness or vertigo is involved or if it's more serious. When a patient complains of vertigo, you want to rule out other causes, such as medications, migraine, or orthostatic hypotension. If vertigo is suspected, consider a referral to an ENT for further workup. Diagnostic procedures that can be performed usually involve patient's head and upper body placed in various positions. If their BPPV is present, it will provoke symptoms. Watch for a nystagmus, which is a positive finding. Examples of these tests that can be performed are the Dix-Hallpike maneuver and the Epley maneuver. Instructions for patients who are experiencing dizziness or vertigo can be as followed. You want to instruct them to sit or lie down immediately when they feel dizzy and rest until the dizziness goes away. Doing this can help prevent the possibility of losing their balance, which can lead to a fall and a more serious injury. You may also want to instruct the patient to use a cane or walker for gait stability if necessary. Also, use of the handrails when walking up or down the stairs, and they may even want to try activities that improve balance, such as yoga and Tai Chi. Patients may want to avoid caffeine, alcohol, and tobacco. Using these substances may trigger dizziness or even make it worse. You want to encourage hydration. Tell your patients to drink at least 8 glasses of water a day, get more sleep, and also to avoid stressful situations. You may also want to consider instructing them to eat a more healthful diet that consists of vegetables, fruits, and lean proteins to help prevent dizziness. Patients should be instructed that if they suspect any dizziness caused by medication, to inform their healthcare provider. In that case, the healthcare provider may need to lower the dose or switch to another medication. If patients are taking an over-the-counter medication, such as meclizine or an antihistamine, they should be aware that a side effect may be nausea along with dizziness. In this case, these medications that may cause drowsiness, the patients should wait to take them when they're not being active or productive. In case a patient is overheated or dehydrated, they should also be informed to rest in a cool place and stay hydrated by increasing fluids. When you have a patient who complains of a headache, it is very important to obtain a detailed history. You'll first want to know how it began. This may help to determine a precipitating event, or maybe it was caused by an illness or an injury. You also want to get a detailed description of how the headache is from the patient. You want to get the frequency and patterns, location of the pain, time to peak intensity, duration, quality and intensity, warning symptoms and aura, associated symptoms and level of disability, triggers, and aggravating or relieving factors. There are several different classifications of headaches, such as sinus, tension, migraine, and cluster headaches. There are 4 general categories of headaches, which are muscle contraction, vascular, mixed, which is a combination of the first 2, and traction or inflammatory. There are several different causes of headaches, which is why it is very important to find out from the patient a descriptive history about their headache. Causes of headaches include tension, emotional stress, fatigue, menstruation, environmental stimuli, glaucoma, ear infections, inflammation of the eyes or nasal mucosa, hypoxia, hypertension, intracranial bleed, aneurysm, muscle spasms of the face, neck or shoulders, cervical arthritis, vasodilators, systemic disease, dental problems, or head trauma. Tension headaches are the most common type of headaches. They are experienced by approximately 80 to 90% of the population at some time in their life. It occurs more often in women than in men. The peak ages are usually between the ages of 30 to 38. There are 2 classifications. There's primary, which occur without underlying pathology, and then there's secondary, which occur as the result of pathology. Tension headaches usually have a gradual onset during the day. They can last anywhere between 30 minutes to a week. They usually occur several times a month. They do not pulsate, cause nausea, and usually are not made worse by physical activity. With a tension headache, it can be bilateral, non-throbbing, and also feel like a dull pressure or band-like sensation. Sometimes there's no other associated symptoms. Non-pharmacological treatment for this could be stress management or relaxation therapy. Pharmacological treatment can include ibuprofen, acetaminophen, aspirin, and sometimes amitriptyline is prescribed for those with chronic tension headaches. Cluster headaches refer to the characteristic grouping or clustering of attacks. Other names for cluster headaches are histamine headache, red migraine, Horton's headache, cephalgia, or sphenopalatine neuralgia. Periods can last several weeks or months and then disappear completely for months or years. One of the least common types of headache, and the cause is usually unknown. It occurs more often in men than in women. It is vascular in nature and is caused by blood vessel swelling. Cluster headaches usually occur at night. They can last approximately 30 minutes to longer than 1 hour. They are usually described as unilateral, severe, sharp pain. Associated symptoms usually include at least one of the following: conjunctival injection, lacrimation, nasal congestion, ptosis or eyelid swelling, and rhinorrhea. Management of cluster headaches are as followed: triptans, which are prescribed subcutaneously or nasally, sometimes 100% of oxygen for about 10 to 15 minutes may help subside the symptoms. Preventative therapy is sometimes given as well. Verapamil is an example of a medication that may be prescribed for this. Anti-epileptic drugs, such as Depakote, may often be given. When these are given, they are slowly tapered off and discontinued as the headaches decrease and disappear. For those with chronic cluster headaches, lithium or calcium channel blockers may be employed. Another treatment management is histamine desensitization and surgical intervention, which may be considered for those with chronic cluster headaches who are not getting any relief from the standard therapy. Migraine headaches without aura are headaches that last from 4 to 72 hours. They include at least two of the following characteristics: unilateral location, pulsating quality, moderate or severe intensity, and the pain is usually aggravated by routine physical activity. In addition to those symptoms, they may also have one of the following: nausea and/or vomiting, photophobia and phonophobia. Migraine with aura have positive and negative symptoms. Positive symptoms may have reversible brain neurological symptoms such as visual flashes, spots or zigzag lines, traveling tingling sensations. It is a gradual development over more than 4 minutes and usually resolves within 1 hour. Negative symptoms are reversible brain neurological symptoms, which may include visual blind spots, numbness, speech or word finding problems, and trouble thinking. Usually these symptoms resolve within 1 hour as well. Other signs and symptoms of a migraine are as followed: cutaneous allodynia. A lot of times patients will have the complaint that their hair hurts. With this, they'll have pain when shaving their hair, combing their hair, touching scalp, resting their head on a pillow, pulling their hair back in a ponytail, for example, wearing eyeglasses or contact lenses, and also wearing a hat or a headband. Other painful events that may occur are water hitting their head or face while they're showering, breathing through their nose, especially in the cold air, cooking over a hot stove, rubbing their neck or shoulders, and hanging their head down or bending over. Problems that may occur while diagnosing a patient having a migraine are visual aura. It may be non-throbbing. It may be bilateral. Sinus pain and pressure, stuffiness, rhinorrhea, and weather association often are present. And sometimes neck pain is often present as well. Non-pharmacological treatment for migraine headaches are eliminating the trigger, which is causing the headache, also biofeedback. On page 90 in your Dumphy book, there are a list of commonly prescribed drugs for migraine headaches. A few examples are triptans, antiemetics, NSAIDs, combination analgesics, and opiates. Prophylactic treatment is also an option, and these drugs are used for migraine prevention. A few examples of these types of medications are propranolol, Topamax, and Depakote. On page 91 in your book, you can also see more prophylactic medications. Abortive therapy in migraine treatment refers to therapy that aims at stopping a migraine once it starts or helping to stop a migraine once a patient feels that it may be starting. A few examples of these medications that can be given for this therapy are phenothiazines, triptans, NSAIDs, and analgesic combinations. And again, you can review the charts on page 90 to 91 that list examples of medications for this. Temporal arteriitis is an emergency situation. If left untreated, it can cause vision problems and blindness. It is a disease that causes your arteries to become inflamed or damaged. It can also be vascular, so it's not limited to just the temporary artery. It is also known as cranial arteriitis or giant cell arteriitis and can occur in other arteries. Signs and symptoms may include visible swelling, a throbbing headache that's usually in the temple region. The patient may complain of double vision or sudden permanent loss of vision in one eye. Jaw pain may be accompanied by chewing, fever, unintentional weight loss, tenderness of the scalp and temple areas, and over the age of 50. To help confirm the diagnosis of temporal arteriitis, labs may be drawn, and results may present with increased ESR, increased CRP. A biopsy of an artery wall is also another definitive measure. If left untreated, possible consequences are inflammation and damage to other blood vessels in the body, development of aneurysms, blindness, eye muscle weakness, or stroke. A seizure can be defined as a transient occurrence of signs and/or symptoms due to an abnormal, excessive, or synchronous neuronal activity in the brain. Epilepsy is the occurrence of two or more unprovoked seizures. There are many reasons a seizure can occur. Several examples of causes are birth trauma, perinatal infection, anoxia, infectious diseases, ingestion of toxins, tumors of the brain, inherited disorders, head injury or trauma, metabolic disorders, or stroke. With the onset of a seizure, there are several diagnostic tests that can be performed. Blood work, to include a CBC with a differential, glucose, electrolytes, liver function tests, serum calcium, a urinalysis, and a drug screen. Other tests may include a EKG, a CAT scan, an MRI, or a lumbar puncture to rule out diseases such as meningitis. The International League Against Epilepsy is the world's main scientific body devoted to the study of epilepsy. It was published in April 2017, and it represents the classifications of seizure types in the epilepsies. The new basic seizure classification is based on 3 key features. Number 1, where seizures begin in the brain. Number 2, level of awareness during a seizure. And number 3, other features of seizures. The type of seizure onset is important because it affects choices of medications, possibility for surgery, outlook, and possible causes. There are new classifications that help with the distinction of seizure disorders. There's the onset, focal versus generalized. Focal seizures were previously called partial seizures. These type of seizures start in an area or network of cells on one side of the brain. A generalized seizure, previously called primary generalized, engage or involve networks on both sides of the brain at the onset. And then there's the unknown onset. If the onset of a seizure is not known, the seizure falls into this category. Later on, the seizure type can be changed if the beginning of a person's seizures become clear. Awareness. Whether a person is aware during a seizure is of practical importance because it is one of the main factors affecting a person's safety during a seizure. Awareness is used instead of consciousness because it is simpler to evaluate. Focal aware can be defined as if the awareness remains intact, even if the person is unable to talk or respond during a seizure. The seizure would be called a focal aware seizure. This replaces the term simple partial. Focal impaired awareness, if awareness is impaired or affected at any time during a seizure, even if a person has a vague idea of what happened, the seizure would be called focal impaired awareness. This replaces the term complex partial seizure. Awareness unknown. Sometimes it's not possible to know if a person is aware or not. For example, if a person lives alone at home and has a seizure at night, in this situation, the awareness may not be used, or it would be described as awareness unknown. Generalized seizures, these are all presumed to affect a person's awareness or consciousness in some way. Therefore, no special terms are needed to describe awareness in generalized seizures. Describing motor and other symptoms in focal seizures. Focal motor seizure. This means that some type of the body is moving during the event. For example, twitching, jerking, or stiffening movements of a body part, or automatic movements such as licking lips, rubbing hands, walking, or running. Focal non-motor seizure. This type of seizure has other symptoms that occur first, such as changes in sensation, emotions, thinking, or experiences. It is also possible for focal aware or impaired awareness seizure to be subclassified as motor or non-motor onset. Auras, the term aura, which describes symptoms a person may feel in the beginning of a seizure, is not in the new classification. Yet people may continue to use this term. It's important to know that in most cases, these early symptoms may be the start of a seizure. Describing generalized onset seizures. These seizures start in both sides of the brain. They're called generalized onset, and they can be motor or non-motor. Generalized motor seizure. The generalized tonic-clonic seizure term is still used to describe seizures with stiffening and jerking. Stiffening refers to the tonic and jerking refers to the clonic. This loosely corresponds to grand mal. Other forms of generalized motor seizures may happen. Many of these terms have not changed, and a few new terms have been added. Generalized non-motor seizure. These are primarily absent seizures, and the term corresponds to the old term petit mal. These seizures involve brief changes in awareness, staring, and some may have automatic or repeated movements like lip smacking. The World Health Organization is revising the ICD-10 to reflect the new classification of seizures. Old terms are still in use. In the management of seizures, there are several factors to consider. General management includes protecting the patient from injury. In this situation, you want to move nearby objects out of the way. Protecting the patient from aspiration. You may want to turn the patient on their side after the seizure ends. Don't put anything in the person's mouth. Don't give anything by mouth until the patient is fully alert. If the seizure continues for more than 5 minutes, you should call 911, note the time that it started and ended. Medication should be given depending on the type of seizure. General management of a patient who is having a seizure are to protect the patient from injury, protect the patient from aspiration. In this case, you may want to turn the patient on their side after the seizure ends or while they're having a seizure. Don't put anything in their mouth. Don't give anything by mouth to a patient until they are fully alert. If their seizure does occur for longer than 5 minutes, you should call 911. Also note the time it started and ended. If medication is available, that should be given. Depending on the type of seizure is what type of medication may be given. Pharmacological management of seizures. On pages 102 to 103, chart 7.1 lists commonly prescribed medications for seizures. The best tolerated AED medication should be selected for the patient on the basis of side effects and drug interactions. Monotherapy is preferred over polytherapy for treating seizures. High dosage of a single agent may be required to achieve seizure control before adding a second agent. Women of childbearing age should be educated regarding the drug interactions between AEDs and contraceptive therapy. Women who become pregnant and have a history of seizures should be continued on current AED therapy that controls seizures and should not be switched to a secondary agent simply because of pregnancy. Medications that are prescribed for patients who have seizures are usually based on the type of seizure the patient experiences and also the classification of the mechanism of action of the medication. Again, on pages 102 through 103 in the chart 7.1, it lists different medications that are prescribed for seizure patients. Educating patients with seizures is very important. They need to be made aware that some of the medications require frequency monitoring in order to monitor therapeutic levels and adverse reactions. Safety issues to consider are swimming precautions, cooking precautions, driving restrictions, and also the advantage of having a service dog, especially if patients live alone. A referral to a neurologist for uncontrolled seizures or combination therapy or even new onset seizures is something important to consider. There are many websites online. For example, Epilepsy Foundation of America has general information and support on seizures, and also patients should visit their state motor vehicle department for information about a driver's license.